Hello, everyone, and welcome to Talk Nerdy. Today is Monday, November 14th, 2022, and I'm the host of the show, Cara Santa Maria. And before we dive into this week's episode, as always, I want to thank those of you who make Talk Nerdy possible week after week, including those of you who are my top patrons on Patreon. If you'd like to pledge your support, just visit patreon.com/talknerdy. This week, I want to thank Daniel Lang, David J.E. Smith, Mary Neva, Brian Holden, David Compton, Gabrielle F. Jaramillo Gonzalez, Joe Wilkinson, Leonard Prince, Pasquale Gelati, Patrick Flynn, and Ulrika Hagman. Thank you all so much. You make Talk Nerdy possible. All right, let's dive into this week's episode. My guest this week is fascinating, so we're going to learn a lot together. Her name is Dr. Fenwa Milhouse. She's a board-certified, fellowship-trained urologist. She specializes in female pelvic medicine and reconstructive surgery, which is also known as urogynecology. She was born in Nigeria. When she was young, her family came to the U.S., where she grew up in Texas. She went to medical school at the University of Texas at Houston, and then she did her residency and fellowship in Chicago. And she is currently working in Chicago. She's actually opening up her own practice in 2023. She's going to answer a lot of important questions about urology, questions that maybe you were a little bit afraid to ask. So this is a good one, you guys. Here she is, without any further ado, Dr. Fenwa Milhouse. Well, Fenwa, thank you so much for joining me today.
Thank you for having me, Cara. I'm very excited to talk to you.
Me too. So ever since you were featured on my dear friend Allie Ward's podcast, Ologies, I've been working with actually, it's funny that I don't want to talk about business much on the show, but the assistant that I work with, Noelle, is the little sister of my best friend. And she's also been working with Allie for several years. So we keep it in the family.
Great.
Yeah. So she was able to coordinate with you. We were able to connect. And I'm so excited to be talking about your area of interest where you've really dedicated your career, your life, which is urology, because there's so many, I think, misconceptions about urology. The first one, right out the gate, people think it's just for dudes, right?
Correct.
Okay. So tell us why it's not.
Yeah. So yes, number one, people think it's for men, and urologists cannot or do not treat women. And it's because anybody who has a urethra, anybody who makes urine and expels urine from their body could use a urologist potentially. We deal with the urinary tract. And so that's not unique to men, as we all know. And so women can have urinary tract issues. Anybody can. So I like to say that urology is for anybody. Anybody's fair game to potentially have a urologic condition that needs attention.
Right. So walk us through, before we dive into like a lot of the kind of nitty gritty about the work that you do, walk us through what it takes to become a urologist. So this is a medical specialty. You went to medical school, clearly, but before you went to medical school, what did you study?
Yeah. So, I mean, I was a pretty boring and typical pre-med student. I studied biology. I got my bachelor's of arts in biology, the University of Texas, Austin. I knew I wanted to probably do medical school, if not some sort of healthcare, career. So whether it was maybe dental school, at some point I briefly thought about physical therapy, but came back to medical school. So a bachelor degree in biology just wasn't like the standard route.
Mm-hmm.
If I had to go back and change it, I would have done something completely different, majored in something potentially in the liberal arts or history. So I did 4 years of medical school, which medical school is 4 years, and then you do residency. And urology residency is 5 or 6 years. The 5 or 6 years just depends on the program you end at. Some programs are 6 years, some programs are 5. The 5 years or the 6 years aren't better than the 5 years, and the 5 years aren't worse or better than the 6 years. It's just whether you get a dedicated, that extra year, if you have a 6-year program, is usually a year of research.
Oh, gotcha.
Yeah, which some programs have and some programs did. My program was 6 years.
I have friends who are physicians who study, like interesting things, but I
Mhm.
don't know why. 5 or 6 years it is long, right? Compared to internal medicine or neurology or
For sure. I mean, but you have to remember, urologists are surgeons.
right.
So any surgical residency is usually minimum, typically 5 years. Now, there are some surgery specialties that are not like OB-GYN, they do surgery. That's a 4-year residency. Um, I believe ophthalmologists, they'll do some eye surgeries. I don't think that their residency is 5 years. But, we're cutting inside the pelvis. We're reconstructing, you know, penises and urethras and another thing. So it seems long, but you kind of want it to be that long for that level of, technical skills required.
For sure. Yeah, I think about my gynecologist, and we'll talk about this more in a bit when we get to it, but the listeners already know this, but my gynecologist, I think she did her kind of standard OB-GYN residency, but then she did a fellowship in laparoscopic gynecologic surgery, which was very helpful for me
Yeah,
because I ultimately was diagnosed with endocervical cancer just this summer and had to do a total hysterectomy as the treatment. And um is that something like obviously hysterectomy? So uterus, fallopian tubes, these are reproductive organs. They're not at all connected to the urethra. So that's not the kind of surgery that you would do. But for women who have, I don't know, pelvic floor issues or prolapse or anything, any complications when they have to undergo hysterectomy, are would you then get involved in a case like that?
100%. So this is where the lines of medicine can be blurred. There are actual urologists who will do a hysterectomy.
Oh, interesting. Okay.
So it's not like we can never do it, but typically a hysterectomy is done with a gynecologist. And then there is, like you alluded to, there are pelvic organ prolapse, which is where your organs or your vagina is falling inside out, uh, which might happen whether you had a hysterectomy or not, by the way. And that could be done easily by, well, I shouldn't say easily, but could be done by a urologist. There are urinary incontinence issues like bladder leakage that then would be, your urologist who would come in. And in the unfortunate event that there's a complication during a hysterectomy that involves an injury to the part of the urinary tract, then that would be us. Our pelvis, there's a lot of things that are next door to one another in our pelvis. So I've been in a procedure where there was the colorectal surgeon, the gynecologist, and myself all operating on the same person.
Right. So, kind of taking a step back, because we'll keep doing this. I'm very bad at not being linear. But taking a step back, you mentioned that. So, was yours a 5 or 6 year residency that you did?
6 years.
6 year residency. So, you had research built into it. Is there also a required fellowship as part of that? Did you do a fellowship?
Oh no, fellowship is not required. So
Oh, okay.
urologists, I mean, and fellowship is really never required unless you're trying to do some like super niche.
Right. Like a sub specialty.
Yeah, so you can, as a urologist, finish your urology residency and literally probably do anything you feel comfortable doing within the gamut of urology. I mean, I know urologists who never do a pediatric urology fellowship, let's say, and will do pediatric surgery,
Hmm.
pediatric urology type things. So I did do a fellowship, however. I did a 1-year fellowship in what we call female pelvic medicine and reconstructive surgery. It's a really long title that basically is similar to what you would consider a urogynecologist. So we treat conditions that involve the pelvic floor that predominantly affect women, not exclusively, but predominantly affect women.
Hmm. And does that open up then to doing care for, like you mentioned, you have the specialty in working with women, but not exclusively. You obviously have all of the background necessary to work with men, but not exclusively. Does that also open you up to this like opportunity that not everybody has specialized training in working in sort of like trans affirmative care or like non-binary affirmative care? Do you work with clients who are like gender nonconforming?
So this is a great question. There is a separate specialty. The possibility is absolutely there. This
Mhm.
is the thing is there is also there's a lot of areas that are crossover. So when you say affirmative care, might include gender affirming surgery, that might include, and gender affirming surgery isn't necessarily just one thing, you know, um, it could include taking the testicles out of a transgendered woman, which isn't necessarily what we consider gender affirming surgery. There are roles for a urologist, even non-fellowship trained, to do that. And then there are highly skilled urologists that might have done really intense reconstructive fellowship. And then also plastic surgeons may be involved in this care. But I certainly, even in just if we're not talking about the gender affirming surgery, just care of transgendered individuals. Because one thing that we have to remember as a urologist is that transgender women will likely still have a prostate.
Right. Yeah.
And that needs to be screened for prostate cancer with age. And so there's care that may be involved. There's uniqueness to that population. And so, of course, I'm trained to do that easily.
Yeah, and it's so important too, I think, with individuals who are navigating the healthcare system to feel safe with their providers and to feel like their providers see them. I remember going to a lecture on just, kind of like general sort of gender considerations within the psychology framework. And it was presented by a colleague who is a trans man. And he told this banana story about going to a physician in a small town where he was living and being like, okay, I need like gynecologic care. And he was like, okay, and we need to check your prostate. And he was like, I don't have a prostate, like to be clear. And he was like, and he like wasn't getting it. And I can't imagine how often, sadly, that happens, not because the physicians don't have the biomedical knowledge, but because they haven't like kept up with just like social knowledge.
Correct. Correct. Yeah. And so you bring a good point. Like, can you imagine how that probably happens all the time, and then as a patient, you have to decide, okay, do I speak up and explain I don't have a prostate? Or do I just subject myself to the rectal exam? It's 2 seconds. You know what I'm saying?
Right. Yeah. Or just like, sure, I'll get the referral,
Yeah.
and then like never follow up clearly. Yeah.
So it is important to know these things. And again, it's not just urologist. You can't just expect, okay, well, I'm just a primary physician. I'm just a whatever, and not have some sense of caring for the diverse population that we serve.
Absolutely. And of course, I think it's so necessary. And there is a connection between being somebody who comes from a diverse background and offering care within a diverse setting. Like, there's the privilege that comes from being an older white cis het man, which like historically was always sort of who you thought of when you saw the doctor, because that's who was like getting into medical school. And then you've got, and they have basically this privilege of being like, everybody who is not like me is just other, and I'm going to assume that I'm the norm. And then of course, people who are just not cis het white men, there are a lot of us, and we think about the fact that we are different in these ways, and maybe if I'm different in this way, others are different in other ways.
Yes, correct. Yeah, I mean, definitely when you're the other, and especially when you recognize you've been the other, and not only just in my professional life, but just in society, you're very cognizant of the fact that your presence even alone defies like expectations. Um, I joke on my social media channels, like when a patient comes to see me it's not uncommon for them to kind of look of like, wow, wasn't expecting my urologist to look like you. Fortunately, most of the time it's like, oh, cool. It's like, we're not expecting you, but this is like, you're cool. Um, and, few and far between where it's like, oh, ugh, this, you aren't what I want, to take care of. But the other thing I want to say in that is because of that, I feel that I, I feel that and we see this in medicine, that I'm more cognizant of like my bias
Mm.
because I know what it feels like to be on the other end of that. And all of us have bias. And so I'm more cognizant of my bias. I am a heterosexual cisgendered woman. So that comes with a privilege. You see what I'm saying?
Yeah, absolutely.
Even as a Black woman, I recognize there are levels to this, you know. And so we all have work to do there and to continue
Yeah,
and take
yeah.
care of patients and give them equitable care.
And when we think about sort of our intersectionality, and we think about what's salient to us, I'm curious, like looking at race for a moment, do you feel like your experience being a Black woman, physician surgeon, and like you said earlier, people are almost like surprised sometimes when they get a referral to you, they show up and they first meet you, but also generally are like, oh, that's cool. Do you think that is geographic? Like, is it because you're in Chicago that you have more of a positive experience? Do you think it would be the same if you were, I don't know, in Alabama or something?
Oh, I do not think it would be different in Alabama. No shade to Alabama. Apparently. But yeah, I will say, so recently I have worked in a small town in Illinois, and it's rural. It's predominantly white. And I was worried because I've trained at University of Chicago for residency. I've worked in Chicago area. So I've never done urology outside of like the large Chicago metroplex, which is, you know, and they're more likely to embrace diversity. And again, I'm saying this, but this may be a preconceived notion even. It's like, okay, they're more willing to accept this diversity. This small town, they're going to have this young Black woman as their urologist, and these are, a lot of farmers and whatnot. Like and this is my bias, I'm saying this knowing like, okay, well, I'm judging them, judging me, you know what I'm saying, before I meet them. And I will tell you, and again, I wrote about this on my newsletter and talked about this on my social channels, that I was wrong entirely. That, it was very, very refreshing. I mean, the people were just lovely, you know. And I really I got a few like surprise faces, but just mostly people that are like, thank you for being here, and just welcoming with open arms. So the world still surprises us in good ways like that. So that's nice. I'm glad to report that experience.
Oh, that's amazing. Yeah, that's wonderful, actually. Especially, I think, when we think about rural parts of the country and how lacking in resources we often see them, especially within like healthcare and mental health care. Like, we know that there are places in the country where people are just like hurting to be seen and to have good preventive care. And so it's what a cool thing that you were able to sort of like serve in that area. What was it like for you, though, going back to like med school and then your residency? Did you find that it was a diverse experience, or was it still like, okay, I'm like the only Black woman in the room?
Oh, yeah, I'm the only Black woman in the room.
Yeah, yeah, yeah.
A lot of that. I mean, I went to medical school in Houston, Texas, and there were 10 Black students in my class, and, we knew immediately because you looked around, you're like, okay, how many of it is us? All right, we got
Which
10.
is That's like horrifying because I mean, I grew up in Texas. I grew up in Dallas, but like you
Yeah,
think about and in Texas, yes, it's the South, but it's also like weirdly like its own country. It's
yes,
Texas.
it is. I grew up in Texas, so I agree.
Oh, so yeah. But like, so I live in LA. Actually, I'm in Florida right now for an internship. But like, generally, I live in LA. You live in Chicago. These are pockets and areas that we think of as being like really diverse, and we think of as having kind of just a melting pot of people from all over the world. But when you look at the statistics, and I don't know if Chicago holds here, but like demographic mixes are actually high. Like there are more Black individuals living in the South than in LA. And so it's so sad when you see that representation is worse
Mm-hmm.
in those areas.
Yeah, this is like going on a deep conversation here.
Right. Yeah, sorry.
We could talk about, how I love Chicago. I've lived here for 14 years now or something like that.
Mm-hmm.
And very diverse, very feels very segregated still,
Mm-hmm. Yeah, and so does the South. Yeah.
and woefully unequal. So you're here in Chicago, where you are born and where you grow up absolutely freaking matters into what opportunities that you will or will not get to be successful. What it absolutely matters for your health and for, again, this is getting deep, but the whole notion just, pull yourself by your bootstraps. Well, I can't do that when the school system I'm in is poorly resourced, where I'm, the community hasn't been invested in, and there's, worse crime, because when you don't invest in a community, what do you think people are going to do? People are going to, be frustrated and be, more likely to be involved in criminal activity.
Yeah, and when they don't have economic options,
Yes.
like, of course, you're going to do what you have to do to survive.
So anyway, yes, that was actually coming from Texas,
Mm-hmm.
which is the South, and it had to be worse. Coming from Texas to Chicago, I will say I really didn't understand structural racism and like the effects of zoning and redlining and social determinants of public health. I didn't really understand that until I was in Chicago, and I was like, wow, if I just go like a couple blocks north and it's a different world.
Yeah. Like New York in that way. It's like block by block.
Yes.
You are literally in different like economic kind of classes. It's nuts. So many important things that I think when we think about kind of social justice and we think about healthcare, we've talked about this quite a bit on the show, so we don't have to like keep going there. I've had like Angela Saini on the show to talk about women and the history of women in medicine. And we've done lots of kind of deep dives into this area, but it's just another example of the fact that you cannot talk about these things as if they're separate. You can't tease these things apart. When we talk about healthcare in this country, we're talking about social justice. We're talking about, as you mentioned, social determinants. Like, I don't know, did you see this documentary recently that came out about like the rate of C-section and infant mortality among Black women versus white women in America? I mean, there's just so much to consider. And so I don't know, like I feel safer. And if you look at all of the healthcare providers that I work with, they're pretty much all women, and many of them are women of color. And maybe this is my own bias, but I feel like more seen, and I feel like I'm going to be more likely to get client or kind of person-centered care when I work with women, and especially women of color.
Yeah, so there's actual science that does show that. Okay, so there's a couple things. So women physicians tend to spend longer with their patients, and they tend to have better patient outcomes. There's been a couple.
Well, there you go.
I'm not saying, please, I'm not saying dump all your physicians that are men. I mean, I have wonderful, wonderful male colleagues that I would trust on my own body or send family to or whatever. I'm just putting out some of the science that we have. And then when we talk about other demographic identifiers in healthcare and outcomes, there has been data that shows that race congruent patients that have a physician that is like within their same demographic, ethnic or racial demographic, they tend to have better outcomes.
Oh, interesting. Okay.
So like Black patients tend to have better outcomes with Black doctors.
Huh. Yeah. And I mean, sort of makes sense. I mean, it's sad that it's the case, but it sort of makes sense.
Mm-hmm.
Like, you see me, you're not going to minimize my complaints or my, concerns. Like, you're not going to say. And I think you see this too with like LGBTQI affirming care. I was talking about this on a previous show, if people remember, but I went to a seminar about, and I work with like a lot of youth, kind of like trans youth or nonconforming youth or gender questioning youth. And one of the things that they would say over and over and over is, if I go to a physician and I tell them like, I've been feeling like I have pelvic pain, or I've been feeling really tired lately, or it's always like, oh yeah, it must be the hormones. And I feel like you see things about like Black women, for example, in childbirth, saying like, this really hurts. Like, I don't think this is normal. And the doctor's being like, oh, you just don't have very high pain tolerance. Just deal with it.
Well, actually, doctors think Black people tolerate pain. Like, that was a whole.
You're right. Historically, you're right. They did.
We can tolerate pain. So we are less likely to get painkillers when we legitimately need it, like after surgery.
Right. So it's not like you can't tolerate the pain. It's like, why are you complaining? You're fine. Just close your mouth. And meanwhile, like, she's bleeding internally, or like something terrible is happening. Like, it's just horrifying.
Yeah. Yeah.
Ugh. And so that's cool. That's cool to hear that, like, I mean, it's sad, but it's, would you say that when you look at the clientele that you work with, is it like just ultra diverse? Like, a lot of people come to you for a lot of different complaints. Do you find that you tend to see more like women and women of color than your like white male colleagues?
For sure. Yeah. I mean, I definitely see most average women patients, if they had their choice, choose a woman urologist over a man urologist if they had a choice. Okay. Now, there's not that many women urologists. There's 9% of us. So,
oh, wow. Really?
yeah. So you often don't have a choice. And I don't want to poo poo on men and by any means. So it doesn't mean that you're settling. But most women, and I hear this all the time, they'll be like, oh, I'm just glad you're a woman because I feel like I can talk to you easier about, because a lot of the stuff we do in urology has to pertain to down there. And so then I think the men too, like, probably feel more uncomfortable with me initially because, I didn't think my urologist was going to be a woman. And here I am. I have to talk about my dick and my erections and my ejaculation and libido. And it's weird. And patients have like been, this is, like, I don't know if I'm going to be honest, doc, I feel a little uncomfortable. And I think where we can shine is just to be able to, like, we have to remember that being a doctor isn't just about what we know about how good our surgical hands it starts with making the patient feel comfortable. It starts with connecting with the person. Because when you don't connect with the person, they're not going to tell you everything. They won't follow, your recommendations. They'll leave with less than. And you won't also be able to help. You won't give them your best advice. So we have to relate to people. And I am thankful that I have that naturally in most cases, able to just kind of make people feel comfortable.
Well, part of that too, it's just like being human and being authentic and not like hiding behind. I have a lot of, physician, but not just physician, like also like psychology friends. And, I work in this field and I work in hospitals and things like that. And you meet people. And I think there's this sad thing that sometimes happens, especially among younger professionals, where they feel like it's, quote, unprofessional to be a human being in the room.
Yeah.
So they're like, I must prove I'm smarter than you. And it's like, what are you doing? Like, all you're doing is making the patient like really uncomfortable. And I heard it just a minute ago. You're like, the guy's like, I don't want to talk about my dick. And like, you're not like flinching at that. You're like, well, you're at the dick doctor, so let's talk about your dick. Like, it's fine. And I think that's so important.
It is.
Like speaking people's language. I see it all the time in psychotherapy when I, drop an F-bomb in the middle of a session and a patient immediately changes with me. And it's like, oh, fuck, I can just talk the way I talk. It's like, yeah, that's the point.
It's so funny. I think that cursing at the right time with a patient actually makes them like you.
Oh, yeah.
I will tell you, I have accidentally been like, oh, shit, or fuck. Not obviously cursing at the person, but, talking about something. And every single time, And I immediately apologized because I was raised in the South and I'm,
Right.
I'm so sorry, sir, so sorry, ma'am. And they'll be like, what for? This is great. They're smiling. I had a 90-something-year-old woman I was seeing and I accidentally said a curse word. And I was like, oh my God, she's going to be. And she cracked up, laughed. And she was like, this is great. So and what it is it shows you're human. And then and then it's like, this is my doctor, but she's human. And so therefore I can be myself, which is a great way to feel when you're seeing somebody for really, when you're vulnerable and trying to, get help.
Oh, for sure. Like going to I would say like urology and gynecology are two areas where there's so much stigma, there's so much shame. Like we even, we did a whole thing on the show. Maybe it was on the other show that I work on, the Skeptic's Guide, where we're like dug deep into the term pudendum, which literally means shame organ. Like it's a whole thing, right? Like it's like it comes from, I think, the Greek or the Latin that literally means shame.
Oh no.
It's so bad. Yeah. So there's like a whole movement now to get like pudendum like changed because of what it carries. And that's the thing. There's a reason we feel shame and stigma. We don't bring it upon ourselves. Like for, millennia, society has made us feel shame and stigma about our reproductive organs and about, the down there parts, like you mentioned.
Oh yes. I mean, patients will apologize when I'm going to examine them vaginally, do a vaginal exam. I'm so sorry you have to do this. And I'm like,
so
what
sad.
are you apologizing for? This is your body. This is my job. And you shouldn't be apologizing for your body. Your body's your body. This is, and they're like, oh, why did you want to do this? And I'm like, I like to help people in this way.
Right.
So there's a lot of shame. And it's the men don't really say that. It's the women. We have been effectively shamed. The men have not, been shamed nearly as much, or if at all. But we women have been effectively shamed about our private parts.
Yeah. Mm-hmm. Yeah. And you work with so many women in your practice, which again, like I'm curious, do other medical professionals sort of know first and foremost that to refer to urology when they're working with women, or do other medical professionals also have the same bias that like urologists don't treat women?
Well, no, because other medical professionals know that will treat urinary symptoms, which again, any person can have that. I will say there's always a little confusion, even from medical professionals, like where the line ends. So where does the line, especially for subspecialists like me, right? I said at the beginning of the show that my subspecialty is similar to what a urogynecologist is. And a urogynecologist is a gynecologist who did a fellowship to kind of learn how to treat urinary and pelvic floor issues in women. That sounds very similar to how I describe my fellowship and what we do in our subspecialty. So where does the line stop for the urologist who's doing that versus the gynecologist? And I get sent, and the truth is, it depends on where you are. So, it just depends on what you're doing. And so I'll get sent. There's certain things that are classically left for gynecologists. Like I'll get sent patients to do their pap smear. I'm like, yeah, no, don't do that. So most of the time it's that confusion within the medical profession, not like, oh, they don't see women. With patients too, this is kind of the patient facing side. Patients tend to be confused on okay, well, you guys do the urinary tract, that includes the kidneys, right? Yes, urologists treat kidney conditions like kidney stones and kidney cancer. But patients may get confused as, well, I have kidney failure. Well, who do I go to? The urologist? And the answer is no. There's a specialist called a nephrologist. Well, what the heck does a nephrologist do that a urologist doesn't do? And I try to explain it like this. I'm a plumber, okay? I'm a plumber. I'm a technician. I use my hands. I'm a surgeon. So if there's a blockage, if there's an anatomic abnormality, like the machinery is anatomically broken, then you would probably, in the urinary tract, okay? So plumber, think plumber, pipes, urinary tract, that's urology. If the engineering is off, like it's like the computer, like the brain behind the pump, if you will, is off. That's a nephrologist. And I tell patients that nephrologists are by far way smarter than urologists. Like they're brilliant, so
A lot of like chemistry and physics and engineering in there.
yes, because the kidney function, what it does is quite complex. So, if it's getting to that area, that's not me.
But where the analogy sort of maybe breaks down, maybe it doesn't, correct me if I'm wrong, is that you do treat things like you do treat like when somebody's dick isn't working. So,
True.
right? Like if somebody's actually struggling with maintaining an erection,
Yes.
and that has to do with blood, not urine, right? Or it has to do with a lot of things.
Yeah. So urologists are just quick and dirty. Urologists cover urinary tract and male reproductive system, which is why most people assume we only treat men, is because we treat the male reproductive system. So when I can now treat female issues, people are like, whoa, confused. Like, well, but do you treat men too? I'm like, yeah, I'm a urologist first. And then I do, so, people have referred to urology as the male gynecologist, which is the closest thing we are definitely the closest thing to that. So yes, if it's the junk, if it's the penis, the balls, the prostate, anything, sexual or reproductive organs in a penis owner, it's us.
So then the question would be, okay, because there's a lot of different reasons let's talk about erectile dysfunction for a bit. I know it's not your specialty, but it is an area.
No, I treat it all the time.
There you go. Okay, good. So, because sometimes it's structural, but sometimes it's hormonal, right? So is this when we would get endocrinology involved, or do you do some endocrinology?
It's not really ever hormonal. It's
rare. Oh,
yeah.
Okay.
So
Gotcha.
There's a misconception that people automatically assume, or the next thing they think of when they think of erectile dysfunction is testosterone. And the role of testosterone is a very indirect role in erectile function. Erectile function is blood flow. A stimuli processed by the brain starts this cascade of events that happen on, neurostimulators on different receptors and ultimately leading to blood going into the penis and being kept there to give a rigid penis. Okay. Testosterone helps with libido, among other things. It does for actually men and women. Not testosterone isn't just a hormone for men, or exclusively for men. So, anyway, so if you are, extreme cases where maybe it would be a factor is if you're extremely low testosterone, but you could even still get an erection then, potentially, right? If the blood is still working and you just put a vibrator to your dick, even though you have no desire, but I put a vibrator to your dick and you might get an erection that you didn't even want. Okay.
Right.
You see what I'm saying? So I really, so it's about blood flow. What I think is a better way to say is it could be organic. When you say structural, like organic, there's something wrong with the blood flow.
Like physically, like the places where it needs to go to are too narrow, or like physically it can't flow.
Yes, like the blood isn't circulating where it needs, how it needs to go, or the nerve. If you can have blood, but like I said, it starts with a stimuli in the brain, and then there's some neurologic components that then get blood opening. So if you have a spinal cord injury, you might have an erectile dysfunction because the nerve channels, you know what I'm saying, versus blood. So there's that. And then there's psychogenic, which is like I have performance anxiety.
Totally. Yeah.
It's like my spouse sucks and I don't have any, you see what I'm saying? Or that kind of stuff. And in those patients, the penis probably works just fine. And you can a telltale sign is ask about a morning erections. Do you get morning wood?
Right. Yeah. And that can tell you're right. That can tell you an awful lot.
Yes. Because if there's an issue with the blood flow, there's going to be issues with the blood flow all the time, not intermittently. And so you're likely not, to have poor morning wood or no morning wood if it's organic. But in psychogenic, they'll be like, oh yeah, I have morning wood every day. Because it's not, it's subconscious. It's not.
Yeah, it's in your head. I mean, it's not in your head, but yeah, your psychology is affecting it for sure.
Correct.
I'm curious, like just to get a little super geeky, when there is an issue with the actual blood flow, like it's not always just one thing, right? So what are the different reasons that somebody might have a organic or biological reason that they're having a hard time getting hard?
So you can have a neuro neuro injury. Let's just put it like that. Okay.
Okay, right. Because obviously your brain is involved in your dick getting hard.
Yes. For instance, some men, one of the risk factors or side effects that are possible, I should say it like that, possible side effects of having your prostate removed for prostate cancer,
Mm-hmm.
okay, is erectile dysfunction. And why does that occur? Well, there's nerves, these really tiny ass nerves that are like basically microscopic, these tiny nerves that are very near, that are important for erectile function, that are very, very near the prostate.
Interesting. Why would that be the case? I mean, of course, because there is no why, but yeah, that's
If you believe in God, talk to him about it. Like, why?
right, exactly. Yeah, it definitely feels like, why is that happening in your butt? But whatever. Okay.
So taking out the prostate can injure those nerves, and men can have issues with erectile dysfunction. That doesn't mean that it can't be treated. We can't put the nerves back. Like, it's done, but there's ways to treat it.
Oh, but like, duh, this is why prostate stimulation is like really sexually like pleasurable for men.
I don't know if that's the case. I don't know.
Interesting. You think other reasons as well?
Yeah.
Okay.
Yeah.
Gotcha.
Yes, that is thought to be an erogenous zone. The other reason, getting back to ED, the other reason is if your arteries just aren't pumping the blood, like you can't get the blood to the penis, and that's through arterial network or whatever arteries.
Right. So you've got like you're getting older, you've got cholesterol building up, or your arteries are getting hard, and for whatever reason they're not flowing.
Smoking, high blood pressure, all those things that you would associate to hardening of arteries. That's like the most common cause of ED, are those set of conditions, and why we in urology will tell you, yeah, what's good for your heart is good for your dick.
Right. Well, yeah.
Like, if you want to measure a measure of your heart health, ask what is your dick doing or not doing. So and ED is I think associated with a 5-fold increased risk of heart disease.
Right. And that's why like a lot of the ED drugs, like they were first developed as like blood pressure medications, or I mean, they're because they help you with your blood flow, and that results in blood flowing to your dick. What about more external, like structural things? I feel like I've heard about like things with circumcision or like foreskin issue. Like, is there anything about like the penis itself on sort of the outside that would affect blood flow?
No, I mean, circumcision might decrease penile sensation, but not erection. There's not that many things on the outside that will affect ED. I mean, if you have a really aggressive penile cancer, which is rare as hell, well, I shouldn't say as hell, but rare, and it's growing into your dick, that it's blocking the places where the blood needs to go, that could be,
Of course. Yeah. Like there's literally a tumor blocking blood flow.
that's like superbly rare type of scenario. But there is something called venous leak. So you need the blood to get there, but you also need the blood to stay there to keep it hard for some time. And what happens is you need the venous network not to pull that blood back out.
Oh, so some people's veins are just like grabbing it early. Basically, it's just like leaking out early.
Leaking out. So it can leak, and that could be a result of like an injury. Let's say you had an injury to your, trying to think of an injury. Like you had an injury to your taint.
Yeah, that sucks. Yeah.
But yes, there's so many slang words for the perineum, and you had a motorcycle injury or something, and then you developed a leak as a result of that, and now struggle with keeping an erection because you can get the blood there, it just doesn't stay there.
Yeah. Yeah.
So that's something, and you might, and again, an injury like that isn't necessarily going to be something that on the outside on the outside, your penis is healed, but on the inside, there's this venous leak.
What about, I feel like let's like bust some misconceptions, but also explain what's going on here because I don't really know. But like when men quote unquote break their dicks, like we don't have a dick bone because we're human beings, right? Like we don't have a baculum, but you can like rip something, right? Like there is a way that you can quote break your dick.
Yes, it's called a penile fracture.
Okay, tell me more.
It's not a bone, but when a guy gets hard, what's happening is blood is filling up the corpora cavernosa. These are, you can think of them as like this cylinder with spaces in them where blood can go in.
Is it like spongy or is it completely empty?
It's like spongy. It's spongy.
Yeah. Okay. Okay.
And it allows for obviously firmness, girth. Men who are erect tend to be girthier. It can elongate. So it allows for that expansion. So if you are erect and you have a penile fracture, what has happened is some injury has occurred to basically tear that the lining of that. And so the blood that is supposed to stay within that corpora cavernosa is now leaking out of that. And what you get is this eggplant looking penis because blood is filling all underneath the skin in the tissues. It's not because there's a tear in the corpora, that house where the blood is when you get an erection, but now there's a tear. And so a common scenario of how you get a penile fracture is you're having sex, but you accidentally go in and out, and you go and you hit like the pelvic bone, the pubic bone.
Right. And then you'd like bend.
And it bends.
Oh,
Yeah.
no.
Fuck. And you immediately, what the presentation typically is pain and immediate loss of erection. Typically, it's not always like this. Pain, almost immediate loss of erection. And then it quickly will become like bruised and look again swollen, look like an eggplant, and it may deviate to the right or the left or something. If you're very unfortunate, you might also tear the lining that in that same injury, you might also tear the lining that covers your urethra. It might involve that too. So now there's blood into your urine, you're peeing blood, and then we have to fix that. So penile injury needs to be fixed surgically. We have to deglove the penis.
Whoa.
Yeah.
Whoa. This is like fascinating. I know this is like sounds super weird and morbid, but I would love to watch one of those surgeries because it sounds horrifying, but also fascinating to see.
I obviously like, I'm going to sound a little like crude, but it's actually a kind of a fun surgery.
Yeah, that's so like, do you have to cut, like, does it just peel right off or do you have to like cut away? Like,
no, it doesn't just peel right off.
Okay. Like you're skinning, like skinning an animal, like, like cut it all the way down. Okay.
You do it from just like, you do it circumferentially. So I'm not just going to like cut down the middle and then like flay it open like a book. Cause then, right. then the poor guy has this incision scar right down the middle of his penis. And ideally you want it, if you're going to have a scar, you want it to be just underneath the glands or the head of the penis. Cause then it looks like, there's a little bit of skin change typically in every man, and especially in circumcised men.
Yeah. And a circumcised guy, they wouldn't even notice, but even in an uncircumcised guy, and half the time it would be like hiding under the foreskin anyway.
Correct.
Yeah,
exactly.
Okay.
So then you deglove it down. It's almost like unraveling a condom or something.
Mm-hmm. Yeah. Wow.
You take the skin and then you find the hole, and like, sometimes it's a pain in the butt, but the trick is you got to find the hole, and it's covered in blood because it's bleed. And so you got all this blood that you kind of have to clear away to find the hole.
But then it just like fills right back up. You're just constantly like washing the blood away.
No, not necessarily. I mean, at some point the body stops, because men don't stay hard. Like if you didn't have the injury, men don't stay hard forever. So
right. Okay. Yeah, that makes sense.
But there's a lot of blood that was there during the erection that's come out.
Right, because eggplant penis.
Correct.
Okay. And so wait, when you deglove it, it's just exposed like muscle?
There's no, it's not like don't think of it like a muscle. It's just another type of tissue.
Oh, okay. So I guess there are no penis muscles?
There are.
Okay.
There is muscle that wraps kind of towards the bottom.
Oh, right. Like, cause yeah, I think guys have like control by their pelvis. That
Yeah,
makes sense.
that's kind of close where we call it the penile-scrotal junction. So where the base of the penis meets the scrotum, there's muscles that go there, and that's important for semen to propel where it needs to go.
Got it.
To allow for conception. So there are muscles.
Which, by the way, I keep saying guys, and I feel bad. Like that's obviously clearly just like terrible shorthand. But like people with a penis don't have. Yeah. Okay. Just to be clear. Yeah.
Yes, I understand. I go interchangeably between like saying male, men, dudes, vice versa for women. So yeah. So then you find the hole, and then you put stitches in it.
Okay.
And you put the glove. You put the skin
you
back.
Put the glove back on.
Yeah. Put it back up, and sew around. So.
Wow. And then, okay, this is an important question. Post injury, and maybe not even just this specific injury, but especially with this specific injury, but post any sort of like penile injury that may cause, like, will it hurt or will it be dangerous to get hard? Do they have to prevent themselves from having an erection while they're healing?
That's hard to do. Like,
right. Because it can happen in your sleep.
They'll be like, yes, it has a mind of its own.
Right.
Hey, and then,
does it hurt when they get hard?
It's sore, but it's not a dangerous thing for them to have an erection. They just can't use it. But it's not it doesn't hurt nearly as much as it did when the first injury just happened. So it's just normal soreness.
How long does it take to heal? Because I'll tell you, after my hysterectomy, which, I explained it on the air, so we don't have to do that now, but I had a total, not a radical, meaning I kept my ovaries, but again, uterus, fallopian tubes removed, cervix completely removed, which means then there was a vaginal cuff that was formed at the kind of upper end of the vagina. So of course I had stitches there, plus all the laparoscopic stuff and like just the deep pain. I couldn't have sex for 3 months. 3 months after my surgery.
Because your doctor told you not to, or because you weren't your body wasn't ready?
It was, we said, let's do 2 months to be safe. And then at my checkup, which was, I think, 6 weeks, she was like, okay, you're healing beautifully, but your stitches are still visible. So I want there to be more time. Like, I don't think 2 weeks is going to cut it. Let's pick a little bit more time just to be safe. So for me, for whatever reason, I healed well, but somewhat slowly, just in the vaginal cuff area. Inside, I was doing great. So yeah.
Typically it's 6 weeks, maybe 6 to 8 weeks. For this penile injury or whatever, usually 6 weeks is the magic time.
Do people get like so sad, especially the ones who like injure it from sex?
They don't, because they're like happy to have it like not injured. They're just like,
oh right, yeah, I'm gonna be better. I can wait this long.
I'll wait 6 weeks. Like these are almost always in the middle of the night type of cases. And they're like, oh my God, can you imagine breaking like your private part?
No. Well, I mean, yes, but no.
You're just like, please help, put me back together and I'll do whatever you say.
Yeah. Oh gosh. Oh man. Okay. Well, I feel like I could talk to you all day. There's like a million more questions I have. I'm not going to be able to ask them to you because we're just like running out of time. But real quick, maybe you can give us, I have a closing question that I'm going to ask you in a second. But before that, maybe you can give us just a rundown of like the most common things that you treat, so that if anybody listening right now, and I'm remembering like 80% of my listenership identifies as male. There's a lot of male listeners listening right now. Obviously, I also have a lot of female listeners and a lot of trans male and female and non-binary and non-conforming listeners. But anybody who's listening, what kinds of things would they see a urologist for?
Okay, so I'll do this in two parts. What kind of things I'll see a urologist for, and then kind of I'll talk about what kind of things that I really like or am like,
right, like your specialty kind of.
Yeah, exactly. So urologists generally would see kidney stones that need treatment, urinary or bladder leakage, would treat any cancers involving the kidney, the bladder, the penile cancer, prostate cancer, testicular cancer, so cancers involving the male reproductive system as well. Would treat other prostate issues that are not cancerous, would treat, I'm blanking, but obviously male sexual dysfunction, which includes ED, low libido or low testosterone, that sort of stuff. So men's health type things.
And vasectomy, right?
And vasectomies, yes.
Which,
correct.
by the way, sorry, another random question. Did you see like a huge spike when all this Roe v. Wade stuff went down?
I personally did not, but I was seeing what I did observe more than a spike. And I think the reason why this is my assumption, why I think maybe I'm not seeing a spike. There certainly has been a spike in the country, but I think it's not been so apparent where I am because it's still safe to get an abortion here in Illinois.
Gotcha. Yeah. That makes sense.
I have been seeing in general, like an increase in men who have never had kids or younger men getting a vasectomy and choosing to get a vasectomy and choosing not to have kids in their future.
I think we're seeing that with women. I think we're seeing it across the board. Just more people saying, I'm not going to be stigmatized by this. I know I don't want kids and I'm sick of people. You just wait until you're older. Like it's not going to happen.
Yes. I mean, why should we, if the person understands and they've made that decision, why should we say, oh, you're just not old enough yet. You're not going to, you know what I'm saying? Yeah.
Right. Yeah. It's gross.
So,
it's gross.
Yeah.
Anyway.
So I've seen that. But
okay.
The reason, and hopefully it stays protected in Illinois. Go vote, everybody.
Mm-hmm. Yes.
Vote, because it's on the ballot. Okay.
Yeah. Oof.
It's on the ballot. If you didn't believe it was on the ballot before, you've seen what has happened. Like overnight.
For sure.
Overnight, like, I don't remember how many states it is now.
So many. Yeah. It just triggered those like weird kind of default laws that jumped out. It was so sad.
Indiana, our neighboring state, they ruled and banned abortion. So,
and I live in California mostly. I mean, that's home to me. So we're fine. We're like a, what do they call it? Newsom, like actually, or the whole left coast sort of said we are like sanctuary state for individuals. But right now I'm in Florida on this internship. I literally bought a t-shirt that says I will aid and abet abortion that I like wear walking around, which I don't know how safe that is, but it's a scary thing. And I want to make sure that my voice is heard here. Like this is not okay. Anyway, that's a whole other thing.
It is. It's okay. So go vote.
Yes, go vote. So the other thing, the things that people could come specifically to you for like your specialty.
Yeah. So, in reality, I'll do most of the gamut of general urology. What I'm really subspecialized in and what I really like to do is focus on sexual dysfunction and female pelvic floor issues. Well, I shouldn't even say female. Pelvic floor issues, urinary and pelvic floor issues and sexual dysfunction, because it really is not unique to vulva owners, okay? So that could be erectile dysfunction, low libido in anyone, pain with sex, which is predominantly in vulva owners. That could be urinary incontinence or bladder leakage, pelvic organ prolapse, or other things happening to a vagina that are anatomically out of whack. Or the vulva, which is the outer part, that are anatomically out of whack. Yeah, so that's and then bladder pain, painful bladder or interstitial cystitis as well.
That's amazing. And how like important, I think about, I don't know, the vagina monologues. I think about these like really sad examples that you hear of where women go sometimes their whole lives being so afraid, or men, but that specifically, referred to people, like you said, with a vagina or with a vulva, who go their whole lives like afraid to speak up that something's wrong. Like, this kind of hurts, but maybe I just put up with it, blah, blah, blah. When there is treatment available that could like massively improve your quality of life.
Yes. Oh my God. I mean, we tend to do that, especially vulva owners tend to do that. We tend to put up with far too much for far too long, whether it's I have incontinence or there's something happening in my vagina coming out that I don't know and I'm too afraid to really look, or it's whatever. And I will say when it comes to the private area, the penis owners tend to not ignore it as much as we do. Um, and 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 I really think it's because, like you said, we don't know that there is treatment available. We just assume it's normal, quote unquote. And it's not normal, it's common. These things are very, very common. And I say that to my patients so that they know that they're not alone, that I'm like, you probably know somebody who has the same thing you do. They just, no one talks about this. It's not some share at the dinner table or the coffee table. You're not, even your closest girlfriends may not tell you that they wear diapers because they can't, make it to the bathroom.
Yeah.
So while it's common, it's not normal.
Yeah, it's definitely not normalized. Like I have a friend who saw a PT, like a pelvic floor PT after her, like, I don't know if it was her second or her third kid, but she was saying that or maybe it was after her first, and she was saying it was so like refreshing to get the help with the things that she was struggling with, but that she heard the saddest stories from this PT about women who literally like couldn't poop without putting their finger in their butt, or like who couldn't yeah, they were leaking all the time, that they were basically wearing adult diapers when they were like in their early 30s, and they just didn't know that there were things you can do about it.
Yeah. People assume it's normal. People assume it's if I'm too young.
Mm-hmm.
And I'm like, no, this is equal opportunities. Equal opportunity. Age may be a risk factor, but it's not, it's fair game. People assume another area that people just assume it's normal and are told by doctors that don't know what to do that maybe it's normal is pain with sex.
Yeah.
Well, that's
Yeah.
normal. It's just one of those things. You know what I'm saying?
Yeah. Yeah. It's really sad. Yeah. And there's a reason. I mean, I feel like there's a long societal reason because of like our patriarchal past. Like sex historically was rape, and rape was sanctioned, and blah, blah, blah. And like women just, okay, maybe that's just something I have to put up with. And it's like, no, you don't. Sex should feel good.
It should. I'm on a mission to have sex feel good for patients who want.
I love that. Oh my gosh, that makes me so happy. Okay, well, I think that's such a beautiful note to like start to close up. So I have to ask you, because I ask all my guests the same two questions, and my guests come from like all walks of life and all different like aspects of science. And they're sort of big and maybe even a little existential. So take all the time you need. Okay, so here we go. Two different questions, starting with the first one, which is, when you think about the future, in whatever context is relevant to you. So it could be personal, it could be professional, it could be, communal, societal, I don't know, global, cosmic, whatever. The first question is, what is the thing that is keeping you up the most at night? The thing you're most worried about, maybe even feeling pessimistic or cynical about? And then on the flip side, so we end on a more positive note, where are you finding your optimism and your hope these days? Like, what are you genuinely optimistic about or looking forward to?
So the first question, I'm a mother. So you worry about what the future will look like for your kids. What direction is our world going in? And it absolutely feels like the world is going to hell. Um, and um, our young people are faced with so much more. And we see the higher incidences of stress and anxiety and suicide and and substance abuse. And I see, I think, and I'm big on social media, so I'm torn, but I'm like, you know, I see how it's can really shape young minds in a negative way. So I just worry I'm not doing enough as a parent sometimes to help my kids be in the best position to deal with the things that they're going to deal with in their generation. I'm an ex-gennial, so I'm a millennial, but old enough in the millennial to remember when like we didn't have cell phones.
Right. We're probably very similar in age, you and I.
And my childhood was no cell phones. My daughter, my youngest, who's 9, her childhood is extremely different. Like devices before she could say my mama, she had a device in her hand. So that's what keeps me up at night and kind of worries me, if you will. Now, what gives me hope, optimism, what I'm looking forward to is starting my own practice. Opening, yes, yay, 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 yay. And being my own boss and really doing patient care the way that I think is that I want to do, that is better patient care, the best patient care that I can deliver is the goal. And so I'm really, really excited. I'm scared because I went to medical school to be a doctor. I didn't go to medical school to be a business owner, but I'm learning, and I'm learning from a lot of wise people. And I have a support system, and a huge support system at home, and a tribe of people who are doing this well, that are amazing to be around and just fill me with so much encouragement, even on the worst days. So I'm
Oh,
excited.
amazing. Amazing. How exciting. So that's coming like next year, right?
Early 2023. So I don't know the exact date, but early 2023.
Oh, so that's not even, yeah, it's next year, but it's already like November. So, wow. Well, congratulations.
Thank you.
And thank you. Thank you so much for being here, for sharing your expertise, for doing what you do, which is so, I think, just like affirmative and necessary, really helping people find their joy. It's so much bigger than just medicine, than just treating a condition. It's really affirming for individuals to be able to live, I think, a fuller life, a life with better quality, which is so important.
I love it. I can't even add to that because
So thank you. Thank you for being here.
thank you for having me. It's been a delight. And I love this.
Absolutely. And everybody listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.